This was a very exciting trial. So it's using an ATR inhibitor in combination with low-dose Irinotecan. And it was a trial that was first in human. We enrolled all type of tumors in this cancer. It was a phase 1 dose escalation and expansion. The trial was first, a monotherapy trial. They found the dose there, and then we had a lower dose that we started on here on this trial. The dose that we used for the ART0380, which is the ATR inhibitor, was 1/5 of the monotherapy dose, and the dose was 200 milligrams of the ART0380 on days 1 to 3 and 8 to 10. And then we used a very low dose of Irinotecan, which was 60 milligrams per meter squares on days 1 and 8 in a 21-day cycle. And so that dose by itself of Irinotecan, we wouldn't expect to have any efficacy as a monotherapy. That was the trial. And then, what we, initially when we enrolled patients on this trial, we wanted to have patients with ATM protein loss. And initially we enrolled patients based on both the liquid biopsy and the solid tissue biopsy. What we did find was that patients who had liquid biopsy, it didn't really correlate with the IHC showing protein deficiency. So we went to do just solid tumor biopsies and also IHC, where you can actually see if there is a deficiency or not of the protein. As the trial progressed, we realized that IHC was the best test to see if the patients had deficiency of ATM. And so currently we only enroll patients based on IHC. And the patients were enrolled into 3 different groups. So they were called either ATM negative, which was a score of 0. And then if they were low, they were 1 to 50. And if they were above 50, we called them ATM high. And this is really important because it correlates with the outcome and the results of the study. So what we saw was that patients who had ATM negative cancers had a very good outcome. And we saw that the response rate for this population was 50%. So 50% had a response of more than 30% reduction of tumor. What we also saw was that even if the remaining patients didn't have a confirmed RECIST 1.1 response, they all responded pretty much. We only had 2 patients that had growth in their tumor. Every other patient either was stable or had a shrinkage of their tumor. So these patients really benefited from the treatment. They had frequent responses. They had a long duration on therapy, whilst the patients who were what we called ATM high with an H score of more than 50 did not respond. They came on, nobody had a response, and the patients came after 1 or 2 scans. And we also looked at the, overall survival and progression-free survival, and it correlated that the patients with ATM negative cancers had a much better outcome. So the median overall survival with ATM negative cancer was 14 months versus 4 months in patients who had ATM high cancer. So a 10-month overall survival benefit if you had an ATM negative cancer. So this is the cool thing about this trial, that we actually were able to find a biomarker that would predict which patients would benefit from the treatment.